For our webinar, Autism Spectrum Disorder, a Primer for Case Managers. I am Erica Hurdle, Program Manager for the Iowa Regional Autism Assistance Program. Allison Drew, REP Program Coordinator, will be joining us to help moderate the questions at the end, so feel free to type those in the question box as we go along. I am pleased to introduce to you today our speakers, Dr. Todd Kopelman and Dr. Kelly Pelzel. Todd Kopelman is a pediatric psychologist who provides evaluation and treatment services at Meadowlark Psychiatric Services in Iowa City and Wendell Johnson Speech and Hearing Center. He is also a visiting assistant professor at the University of Iowa Department of Psychology. He has coordinated 3 federally funded research projects evaluating the use of telehealth with young children with autism and severe challenging behaviors, served as the president of the Autism Society of Iowa, and co-teaches a graduate course on autism spectrum disorders. Kelly Pelzel, PhD, is a pediatric psychologist who provides evaluation and treatment services at ChildServe's Iowa City location. She is also a visiting assistant professor in the University of Iowa Carver College of Medicine. Dr. Pelzel received her BA from UNI and her PhD from the University of Utah. She completed her predoctoral internship at Primary Children's Hospital in Salt Lake City and completed a LEND postdoctoral fellowship at the University of Iowa Healthcare Center for Disabilities and Development. Dr. Pelzel additionally serves on the Regional Autism Assistance Program's expert panel and is a board member for the Autism Society of Iowa. And now I will turn it over to you, Dr. Kopelman and Dr. Pelzel.
All right. Thank you, Erica. Kelly, thanks for co-doing this with me. I appreciate it very much. I'm going to start us off, and also wanted to thank Child Health Specialty Clinics and the Autism Society of Iowa. Okay, let's see if I can advance my slides. So what we're hoping to do is provide an overview. It'll be a brief overview given that we have an hour, but about autism spectrum disorders. And you can read our objectives here. I'll go through them quickly. But hopefully by the end of this, you'll have some familiarity with what autism is, some of the core characteristics or symptoms, an understanding of adaptive functioning skills and deficits associated with autism, be able to identify evidence-based interventions for autism spectrum disorders, be aware of challenging behaviors and options if you are working with somebody who's experiencing a behavioral crisis, and then be aware in general of resources that we have available in Iowa for autism spectrum disorders. Before going into any of that, though, just a brief touch on language usage in the area of autism and disabilities in general. You may be aware of this, but some people have preferences for different types of language usage. That could be person-first language or identity-first language. Person-first language, you can see some examples there. Like if I was using person-first language, I might say I am a middle-aged man with no hair. In the area of disabilities, examples are I am a person with a disability. For example, more specifically, I am a person with blindness. Or talking about autism, I am a person with autism. That is contrasted with identity-first language, where the identity comes first. So I am disabled, I am blind, or in the case of autism, I am autistic. So both of those types of language are used, I would say quite a bit, and there are different preferences that different individuals have. As a kind of a general overview, I would say that autistic individuals who are verbal and able to communicate about their preferences often go with identity-first language, versus researchers and caregivers of those maybe who have lower verbal skills may use person-first language. I tend to just ask individuals what their preference is. For the purpose of this talk, we are going to use both interchangeably. And there are just some examples of what you may see as you're talking to individuals or reading in the area of autism. So what I wanted to start with, just kind of an activity to kind of stimulate things, is thinking about associations that you might have with the word autism when you hear autism. So if you want to, you could type this into the chat. But kind of what comes to your mind first of all? Is it specific features or characteristics that you've heard about or seen? Is it characters from TV shows or books? Or is it somebody you know, or maybe even yourself? So if anybody is willing to type into the chat box, that would be great. All right, I'm seeing some comments come in. All right. Oh, quite a few. Thank you. Not a shy audience. I love it. Wow. Okay, because we only have an hour, I'm not going to read those, but you read them out loud anyway. But I appreciate that, and it's a variety of perspectives. I'm going to share some of my own perspectives, and I'm going to give away my age pretty easily. But as far as I can remember, the first time I heard about autism was this movie, Rain Man, which some of you may be familiar with, depending on your age as well. It came out in the early 90s. And it's a good movie. It's a younger Tom Cruise there with Dustin Hoffman, and Tom Cruise plays an autistic adult who has what are sometimes referred to as a savant skill or a specialized skill that his family member, played by Dustin Hoffman, takes advantage of. They go to Las Vegas, win a lot of money. There's more to it than that, but that was my first kind of awareness of this thing called autism. Around the same time in the 90s again, there was a book. It's a really good book written by Oliver Sacks, who's a pediatric neurologist. And he wrote a chapter in this book called The Self-Reflective Autistic Woman. And it was a really interesting description of this woman here, Temple Grandin. Some of you may be familiar with her, and just about her life and her experiences and how she views the world. Temple Grandin speaks fairly widely and has been for a few decades. I would say if you're interested in autism and have not heard Temple Grandin present, she is a fascinating individual, really an exemplary individual. And I can't do service to her and her life. There is a movie about her that came out a few years ago called Temple Grandin, but she is autistic and had a very challenging early childhood, just kind of navigating what it was like to have autism. She had very supportive family, especially her mother, and she went on to get her PhD in animal sciences. She is a professor, and she is internationally known for her research, some of which is directly related to perspectives or insight that she has with being on the autism spectrum. A lot of it is in the area of agriculture and cattle shoots specifically. Really fascinating. This whole presentation is not just going to be about TV shows and media, I promise, but just really quickly, wanted to kind of convey the idea that there's a lot of autism in the media. Again, this is another movie that I grew up with. I don't know if many people are going to be familiar with it anymore. It's an older one. That's actually Leonardo DiCaprio there when he was younger. And the person next to him is Johnny Depp. And it was a movie that took place fictionally in Iowa called What's Eating Gilbert Grape? And Leonardo DiCaprio plays somebody on the spectrum. Moving forward, there have been a lot of like detective type shows with characters who either specifically or explicitly have autism, or one could easily make an argument that they do. This is about Sherlock Holmes with Benedict Cumberbatch. This is a French show, which I really enjoyed, called Astrid, where Astrid, who is on the right there in the blue sweatshirt, is specifically has autism, and they talk about that quite a bit in the show. There have been documentaries that have come out in the last few years about autism, including what it's like to, as adults, develop relationships and date while on the spectrum. This one is called Love on the Spectrum. It's on Netflix, and it's been pretty popular. There are a few different versions. I think the first one took place in Australia, and then there's one in the United States as well. Other shows featuring autistic individuals. There's one called The Extraordinary Attorney Woo. That's a Korean show, also on Netflix, very entertaining. I don't know if this character has autism, but have certainly read people thinking that she's written as if she might. This is Tina from Bob's Burgers, one of my favorite shows as well. So again, a lot of representation of at least a type of autism in the media. And I would say in the last, I don't know, I've been around long enough, maybe in the last decade or so, I've seen kind of a shift in how autism is sort of thought about or conceptualized. And a lot of people look at it as a positive. I've seen this on shirts and cups and tags that autism is my superpower. In other words, autism can be associated with a different way of viewing the world that is not good or bad. It's different, but in certain situations, it can convey or provide a lot of opportunities or strengths. Somebody with autism can really contribute in very positive ways specific to characteristics of that diagnosis of autism spectrum disorder. And I think that's a really important voice that needs to be out there. And at the same time, when I think about autism spectrum disorder as a person, a clinician, but also a person, I think about some of the individuals that I've worked with where, to be honest, their parents may not think of autism as consistently anyway being a superpower. And this is one individual in particular that Kelly and I have both known for many years. This is a young man named Jacob. His mom gave me permission to talk about him. I've known Jacob for decades. And he is a wonderful man, very caring, very loving. And he has autism, has since, well, probably since birth. He was diagnosed very early in his life. He is nonverbal. He has an intellectual disability, and he has some very challenging behaviors, especially, unfortunately, in the last several years. So he engages in pretty severe, highly severe, I would say, self-injurious behavior, where he hurts himself, he beats himself on the chest, he's bitten himself, he's scratched himself. Here's another example here. And he is also highly, highly aggressive. He will hit and bite and kick and destroy things. This is a picture of my friend Mary, his mom. And this makes me sad to look at, kind of the look in her eyes. And so I guess kind of the take home for me is that autism is a spectrum. It is autism spectrum disorder, and we need different types of representation for the different strengths and needs of individuals with that diagnosis. So I really view autism as, like it says here, a complicated story. And just a few statistics, and these do not apply to everybody, but it is important to keep in mind that compared to what, for lack of a better term, typically developing individuals, that means individuals who don't have autism or another neurodevelopmental disorder, children with autism are at high risk for injury and death from things like drowning. They are at high risk, especially females, of suicide attempts. They're at high risk of being sexually abused and being physically abused, and being a parent or caregiver of somebody with autism can be associated with high levels of stress. And I've seen that firsthand over and over again. That is not always the case, nor should it be the case if we had different supports in place in our environment. But that is the reality as it stands currently, in my opinion. So this is a very well-known phrase. I've heard it many times. I'm guessing some of you have heard this as well. And I think it just kind of sums up the point I was trying to make. Stephen Shore is an autistic adult. He is a professor. And several years ago, he said, if you've met one person with autism, then you've met one person with autism. So again, I think just keeping in mind that point is really important in our lives and in our work. So with that background in mind, I'm going to spend just a few minutes talking about what autism actually is, what kind of the features or characteristics are if you're doing an evaluation of autism. So we use the Diagnostic and Statistical Manual, or the DSM-5, the 5th version of that. If you open that up and you were looking for what autism is, this would be the definition. So the first part of autism is that it is associated with significant difficulties or deficits in what's called social communication and social interaction. And those have to be present across multiple settings or contexts. In other words, a person can't just have autism at school, but then they go home and it turns off, or at work, but not, at school. You have autism because it's a core part of who you are. It's across all areas of your life. And so somebody with autism is going to experience challenges with what's referred to as social and emotional reciprocity. And to kind of just break that down, difficulty like approaching other people for social purposes, having a hard time engaging in social chit chat or back and forth conversations, difficulty sharing their interests socially with other people. Those are all characteristics of autism. Somebody who is autistic also may have differences or difficulties in their nonverbal use of social communication. So that can be things like having a hard time combining eye contact with facial expressions or gestures, or not using a lot of eye contact or facial expressions or gestures, which if you're talking to somebody and they're not looking at you or they're not gesturing or you can't read the tone of their voice, it may make it more challenging for you to make some inferences about how they're feeling or what they're thinking in a situation. And then the third kind of broad social area that we look at with autism is this pattern over time. And it's going to depend on the person's developmental point in their life and their age, but struggling with making and keeping different types of relationships. So making friends, keeping friends, or when they're younger, difficulty engaging in what's called creative or imaginative play. So all of those characteristics would have to be present. A second area that we look at diagnostically beyond that social piece, and I apologize for the long list of words here, all combined, but are called restricted and repetitive patterns of interest or behavior. And I'll break that down for you. So there's 4 symptoms, and at least 2 of them would have to be present in an individual for them to possibly have autism. So the first one, you can just think about it as repetitive stuff, repetitive speech or repetitive behavior. Somebody might say the same words over and over again in the same tone of voice. They may repetitively organize or line things up. They may have repetitive body movements, which are called stereotypies. Sometimes people commonly call those stims. So this is just a picture of a clip that's available on YouTube of a young child named Quinn who has autism. And you can see here he fell asleep after he lined up all of these items on his bed. And so that is kind of a classic type of lining up that you may see. It's important to keep in mind that developmentally, children line things up who do not have autism too. So we're not looking at any one behavior in isolation. It's a combination of things. A second behavioral feature, you can think of it as repetitive stuff, doing the same thing over and over again and getting kind of rigid about that. So insisting on doing things very much in the same way. And again, it's important to keep in mind that most people have some things that they have preferences for. I wouldn't be dressed this way, not that I'm formally dressed, but if it was Saturday and I was mowing my yard, you know, I'm a little bit more flexible with that. I like to know what day it is so I know how I'm supposed to dress and what I'm supposed to do. Somebody who has autism, is autistic, may struggle with even very small changes in their routine. I've worked with children where if they had a different color fork than they're used to, or it was put on at a different angle on their plate, they may have a huge meltdown. I've worked with a few children where if there was road construction and they had to take a different route to school or to the mall, they might engage in very high rates of self-injurious behavior because it is different than the norm. That is the level of rigidity that I'm talking about. And then strong areas of interest is another behavior that we look at. It can be interest that most people compared to that individual's developmental level would have, or it can be interests that are not bad at all, but they are unusual for that developmental level. And there are countless examples of this. I just put these pictures in here because I've worked with individuals who have interests in these areas. So it makes me think of those individuals. I worked with a child who was very into water towers. And he would insist that his parents stop in every small town in Iowa so that he could get out and look at the water tower. Saw another child who did the same thing with porta potties. So those are not bad interests, but if you talk to a parent whose child has those interests, they might say, well, that's different than my other children. And I'm not sure why they're so into those things. Oftentimes it's things that tend to be a little bit more mechanical in nature. like vacuum cleaners or elevators. Doesn't have to be, though. And then a final symptom that we look at when we're thinking about from a diagnostics point of view if somebody might be on the spectrum are hyper or hyporeactive behaviors to sensory input in the environment. So unusual responses to light, sound, touch, or taste that can be very bothersome for that individual. And this is a child of a colleague of Kelly and I's, named Erin Enyart, who's very involved in the Autism Society of Iowa. This is her son. And just examples in one picture, he's in the dark. Some individuals with autism are very bothered by light sources. And then a very common feature of autism as well is sensitivity to certain food textures or tastes. Just a little bit more background on autism. Now I've kind of quickly gone through what the characteristics or features are. As I mentioned, it's a pretty broad spectrum. About a third of individuals meet the criteria for an intellectual disability. Most of those are in the mild range of intellectual disability, but some are in the moderate to severe range. And about another 20% probably have what's called borderline cognitive functioning, meaning below average functioning, but not an intellectual disability. About 30% have a seizure disorder of individuals on the spectrum. And then very common concerns that can be associated with autism are sleep difficulties, toileting difficulties, as I mentioned just a minute ago, feeding difficulties, and behavior concerns like aggression and self-injury. And we'll talk a little bit about that later. And then also working in the area of psychology and psychiatry, it's important to note that a lot of individuals, it's very common, who have autism have other what we call co-occurring or comorbid diagnoses. So this is a study that came out a few years ago, and it shows how common different diagnoses are on the far right in the general population, and then next to that among individuals who are autistic. And the take-home point here is that for every single one of those common diagnoses, they are more common in the autism population compared to the general population. So I just bolded a couple of those. Anxiety is almost 3 times as common. ADHD is almost 4 times as common. So we oftentimes are not thinking about per se treating the autism, but we're treating anxiety or ADHD or challenging behaviors that are associated with it. Just a few other quick facts, and then I'm going to turn it over to Kelly. 4 symptoms of autism. The symptoms that I described a few minutes ago typically occur early in somebody's developmental period. In most cases, by the age of 3 or 4, we are going to see those social and behavioral characteristics that I described. That said, that doesn't mean that everybody is diagnosed in early childhood. In fact, it is becoming much more common for a diagnosis not to be made until adolescence or even adulthood. People are missed. Our understanding of the diagnostic criteria themselves is also evolving. And so we are picking up on individuals, and I would say specifically ethnic and racial minorities and females who were not identified maybe 15 or so years ago, even 10 years ago. As far as how common autism is, the best kind of epidemiological number that we have is from the Centers for Disease Control. They do a population-based survey every few years. And in 2023, the rates indicated 1 in 36 school-aged children in the United States meet the criteria for autism spectrum disorder. So I did some quick math. Don't take this to the bank, but it's a rough estimate that would translate to at least 22,000 children in Iowa with that diagnosis. So if you think about 1 in 36, that could be almost 1 child in every classroom in a school. Certainly 1 child in every 2 classrooms, I would guess. So it really is very common. It is one of the most common developmental disorders. Autism is more common in males than females. This is certainly an area of discussion and debate and research. It could be another talk about why that is. but the research suggests, at least at this time, that that is the case. Okay. So I'm going to turn it over to Kelly now, and she's going to talk about autism and adaptive functioning.
Yes, so we want to spend a little time talking about adaptive functioning because it's an important metric. It's an area that can be of concern for many individuals with autism and is important for making decisions about care and support. So adaptive functioning broadly is a collection of conceptual, social, and practical skills that are learned and performed by people in their everyday lives. I like this definition, even though this is really old, that Sattler gives here, because he talks about the degree to which individuals are able to function and maintain themselves independently within the context of culture, of what the cultural situation is and the environmental situation is. So obviously, different kinds of skills are going to be more or less important in different types of environments, emphasized or de-emphasized, or reinforced or not reinforced. And so that's important to take into consideration as well. More specifically, if we think about those conceptual, social, and practical skills with autism, when we're talking about conceptual skills, we're thinking about things like language and other forms of communication, literacy, reading, money skills, number skills, and then an individual's ability to engage in tasks independently and have good self-direction. Social skills can include a wide variety of things. Here you see interpersonal skills, social responsibility, things like self-esteem. We want to make sure individual what they can kind of sense in terms of not being taken advantage of. Social problem solving, following societal rules, obeying laws, those sorts of things. Leisure skills also oftentimes falls into this category. And then the third big area for adaptive functioning, adaptive behavior, is practical skills. So activities of everyday living, things like self-care skills, things around the home, things at work, healthcare and safety skills, getting around to places, being able to follow schedules, and then kind of beyond money skills like being able to count money, actually being able to use it, to pay for things, as well as use technology like a phone. And so oftentimes, when people come in to see me for an autism evaluation and other kinds of evaluations as well, me and other psychologists, we're taking an estimate of their adaptive functioning because it's very useful. First and foremost, when we're thinking about intellectual disability, the emphasis on whether someone meets criteria for intellectual disability is on their adaptive functioning skills. That's a shift, I think, from previously when there was more of a focus on the IQ score. That's really de-emphasized in the current DSM. The other great thing that it does, if we take a look at these kinds of skills, is we can see where a person's strengths and weaknesses are. And when we talk about strengths and weaknesses, we can talk about them in a couple ways. One is relative, meaning when we're comparing an individual's skill level in an area to their skill level in other areas. So within a person comparisons. And then normative strengths and weaknesses are comparing them to the population. What areas are areas they're doing well, and where are those deficits? Sometimes people measure adaptive functioning to see progress, like results of an intervention or a treatment that individuals receiving. And then another way you can use adaptive functioning is to look across environments, because like I said, things are naturally going to look different across different environments because the demands are different and what's important in that environment is different. So many autistic people have adaptive functioning deficits. And this is true both for individuals with intellectual disability as well as individuals without intellectual disability. And when we think about why that might be, as particularly for individuals that maybe don't meet criteria for intellectual disability, that have average cognitive or above average cognitive skills, you know, oftentimes things like social communication deficits or limited social engagement, imitation skills, those kinds of things that fall in with the diagnostic criteria are gonna limit adaptive functioning. Also, it's also true that oftentimes people with autism have very uneven cognitive profiles. So they may be very strong in terms of visual spatial skills, but weaker on the verbal side of things or on the working memory side of things. And sometimes, particularly for individuals who in the past may have like fit for like an Asperger's disorder label, sometimes they can have very strong cognitive skills, particularly verbal cognitive skills. They're going to mask those adaptive deficits. So it's really important to get a full picture in that case. Okay, I'm going to switch gears again, but I'll keep going. So we're just trying to get you a lot of information in a short amount of time today. We're going to talk about evidence-based interventions for autistic individuals. And when we talk about interventions, it really can run the gamut because they're so individualized for what the person needs to be working on. You know, these are just a few goal areas. When you're doing a treatment, when you're doing an intervention, it's always done with what that goal is, with that in mind. And that goal is always, well, hopefully always, a collaboration between the individual, their family, the clinician, that are coming up with a shared understanding of what's important and what everyone wants to be working on. So it can be improving communication, social functioning, and play skills, improving adaptive functioning or academic skills, decreasing challenging behavior, so behavior that's dangerous or destructive, addressing those comorbidities, those co-occurring disorders that Todd was talking about through maybe like medical or psychiatric care, promoting independence and quality of life, particularly as we think about people in adulthood. These are going to be really important goals for many. And the other thing I'll say as a clinician is when we're thinking about a specific treatment, and particularly if it's a time-limited kind of treatment or intervention that we're doing, we're still thinking about these overall long-term goals and long-term outcomes that that are important to people. But sometimes we have to kind of scaffold. And so we also think about in the short term, what are we going to accomplish over the next 12 weeks or 6 months or however long you're thinking the intervention is going to be. And I'm going to be covering evidence-based interventions, and that's because, you know, resources are really limited, and there's a lot out there for individuals with autism, and some of what's out there doesn't have a lot of research showing that it works. So, you know, keeping in mind that everyone's time and money are limited, we have to make choices. And for me, as a psychologist, I'm going to make choices and recommendations based on what I see in the literature, what science has shown through studies to be effective. Because I want people achieving those goals and desired outcomes, and that's good information for me to know what generally is going to work. Of course, there's always lots of individual differences as you get into an intervention. Just a few basics here about early intervention specifically is with autism, we do want children in intensive intervention as early as possible. The research supports that. And by intensive, you know, it may be looking at something that's across interventions and across what families are doing at home, about 25 hours of work a week and developmentally appropriate activities. We want programs with low student to teacher ratio. We want families to be involved, lots of opportunity for kids to practice with typically developing peers, again, peers without developmental disorders or neurodevelopmental disorders. Certainly we want interventions where they are measuring progress as they're going and adjusting their approach as needed based on the data. But there's lots of structure, routines, visual schedules, that sort of things. And although this is oftentimes the trickiest part, that everyone's thinking towards generalization. So outside the treatment room, strategies to make sure the child's still able to show this emerging or newly acquired skill. These are kind of my go-to for sources for thinking about what's been summarized in the literature in terms of effective treatments, in terms of evidence-based interventions. First is the American Academy of Pediatrics. And they have kind of a nice widget on this website for primary care and pediatricians. It's for them to be able to think about the age of the child and the goal area and that sort of thing to be able to make appropriate evidence-based recommendations for intervention. The National Autism Center National Standards Project, unfortunately, has been delayed in getting out updated list of evidence-based interventions. So their most current list is now getting fairly dated. I think it's from 2015. And they were hoping to get a new list out in 2021. I don't know what the story is there. But everyone really liked it the last time they put out an updated list. So I haven't lost hope that they may do so again sometime in the future. This third website is called Association for Science and Autism Treatment. And it's actually a parent-run organization, but parents who are very invested in evidence-based interventions. And it has a lot of really neat information on it. And then the one I actually use the most is the National Professional Development Center on Autism Spectrum Disorders, which is out of University of North Carolina. And that has been updated pretty recently, I think 2020. They did a big literature review and updated their list of what is considered evidence-based. So looking across all four of those sources, these are interventions that are supported by scientific evidence. Applied behavior analysis, ABA, does have a lot of evidence, in part because it's been around for a very long time. So this would include things like discrete child training and functional communication training. Another approach that's become more popular in recent years is called naturalistic developmental behavioral interventions, NDBIs, which is kind of a mouthful. These are approaches that blend ABA with more naturalistic and developmental approaches. So this would be things like Project Impact, Early Start Denver model, those kinds of interventions. For a little bit older kids, for thinking about psychotherapies, cognitive behavioral therapy, and self-management therapies have good evidence. Social skills training, including peer-based strategies, social stories, social scripting, groups, those all have good evidence as well. And then working with a speech-language pathologist to work specifically on communication and language training has good evidence as well. Here are a few other additional strategies that are supported by scientific evidence. So visual supports, things like picture schedules and other other supports to let children know what they have to do and where they need to do it and when they're done. Very helpful. Naturalistic teaching strategies. So working not like at a table, you know, and but down on the floor with toys and in the environment the child's in most of the week, that's definitely supported. Modeling, either live or using video modeling to teach skills has good evidence. And then, as I kind of alluded to on that first slide about early intervention, parent training, having parents involved, teaching and coaching them on what to do. There are some interventions that are, where parents are involved all of the time. And then other interventions where individuals are working with the therapist, but a lot of those where a child is working with a therapist have now included a parent training component. Okay, these are some interventions that have some good looking data, but they don't make quite the cut for like the highest tier in terms of scientific evidence. So they call them promising practices or emerging treatments. One is the name brand treatment called TEACH, Treatment and Education of Autistic and Related Communication Handicapped Children. That's out of University of North Carolina. It's been around for a very long time. Again, as a whole, as a program as a whole, it doesn't have quite as much data as some of the other ones I've just talked about. Technology-based treatments, computers, other devices, again, because it's newer, still gathering evidence on those kinds of things. Music therapy. Music therapy is one that's coming up the ranks, where it used to have very little evidence. Now it's in that promising or emerging treatment category, and it'll be interesting to see what it does in the future. And then developmental or more child-led approaches, such as floor time, the play project, again, are in this emerging treatment category. Treatments with very limited scientific evidence would be like gluten and casein-free diets, facilitated communication, or facilitated typing, auditory integration training. Those are all treatments that do not have good scientific evidence at this time. And then we have a couple here that would be not supported by research and may be unsafe. So we do not recommend them. So chelation, which is a treatment where the theory is that you're removing heavy metals from the body to help with the symptoms. And then very high dosages of vitamins and supplements, also not recommended. So
All right.
back to you, Todd. Yes.
Back to me. Thank you, Kelly. So I just want to spend a few minutes talking about some behavioral concerns that are common with individuals on the autism spectrum. And I'll talk about what those can be in a little bit more detail, but want to just kind of start off by talking about why we often see individuals who have autism or autistic engage in these types of behaviors like aggression and self-injury. One of the main reasons is because of the association between autism and communication difficulties. And that probably makes sense at kind of a basic level, that if you're a child and you're not able to verbally communicate effectively or even non-verbally communicate effectively your wants and needs, you may look for other strategies that are going to get a response from other people. And so if you pinch somebody or throw something and you notice, hey, my mom or dad looked alarmed, but it resulted in them coming and picking me up or maybe giving me something that I wanted, behaviorally we would think that's a behavior that may continue over time if it served kind of a purpose for that child. Also, many people with autism experience those restricted and repetitive behaviors and interests. And so that can be associated with those behaviors as well. So for example, if somebody has a strong interest in cars or in water, they may gravitate towards those things. Or as I mentioned before, I've worked with some children who get very upset if there are small changes in their routines. That's probably a core part of what we think about as being autism for that person, but they maybe get very upset when those behaviors invariably occur where there's road construction and the parent can't do anything different. So why do we get concerned about challenging behaviors? This may sound like Dr. Obvious here, but there has been a lot of research conducted on this. Challenging behaviors are associated with high levels of parent stress and teacher stress. So it may not always be the autism itself as much as the behaviors that are associated with autism or the social challenges associated with autism that cause stress for parents. Individuals, children who engage in high rates of challenging behavior, statistically, they have a higher risk for being restrained, unfortunately, and abused. And you may have seen articles in the news, including in Iowa, of children who at school have been restrained or abused, or in their own homes or in group home settings, unfortunately. That certainly is the minority of cases. That is the exception, but it is also a reality that that can happen. And then just thinking about somebody's life and their opportunities in life to live a fully engaging, wonderful life. If you are engaging in a lot of these behaviors, it kind of closes doors for you, closes opportunities. So somebody may be in more of a restrictive classroom setting, even like a classroom by themselves. They may have restricted opportunities as they get older for where they can live if they engage in severe behaviors. And then also important to keep in mind that children who engage in challenging behaviors, if they don't receive good treatment, oftentimes grow up and become adults with challenging behaviors. Some people do kind of mellow out, for lack of a better term, as they get older, but the research really does show that these behaviors tend to persist developmentally unless something causes a change. There is an intervention. So these are the most common types of challenging behaviors that we see. So physical aggression, self-injurious behavior, destruction of property, and what I would call very severe non-compliant behavior. And again, a lot of this can be coming from communication difficulties, maybe a child not understanding what is expected of them or not being able to communicate their wants and needs. By definition, to me, challenging behaviors are behaviors that interfere with that individual's daily functioning in one or more settings. There are other common challenging behaviors, at least I think of them as challenging behaviors. Wandering, sometimes referred to as elopement, is very common in autistic individuals, and unfortunately it leads to fatalities, not uncommonly, including in Iowa. I have known individuals who have been unfortunately hit by cars because they wandered away from a facility or home. Some persons with autism just have a lack of awareness of what can be risky or dangerous behavior, so may run into traffic. Other types of behavioral concerns that are very common are sleep difficulties. I have worked with a lot of individuals who report, or their parents tell them, that kind of a chronic long-term issue is having a very hard time both falling asleep, but then also staying asleep. So I have worked with children who wake up at 1 or 2 o'clock in the morning and they are ready to go. They are up, they are alert, and they do not want to go back to bed. Food selectivity, again, only wanting to eat certain types of foods, could be often based on texture, but I've seen, colors of food, flavors of food, things like that, that can cause difficulty with physical development. Toileting concerns, delayed toileting, very, very common. And then, as I mentioned, medical concerns. So about 30% at least of autistic individuals have a co-occurring seizure disorder. Unfortunately, that can become very life-threatening, life-concerning, but also issues like chronic constipation, which is related sometimes to the toileting difficulties. So there are a variety of behaviors that can co-occur with autism. As far as treatment approaches, I'm just going to speak about this very broadly. But for those behavior concerns that I just mentioned, probably two basic approaches or options that have the most research to support them. The first is medication management. So we don't think about medications as being specific per se to treating autism, Autism is not something that needs to be treated. We're just treating those symptoms that can interfere with somebody's daily functioning and quality of life. So there are medications that are FDA approved for severe rigidity and disruptive behaviors like aggression. There also sometimes are medications that can be used for things like significant sleep difficulties or ADHD type behaviors that can co-occur with autism. And then the second area, as Kelly mentioned earlier, is behavioral therapy or applied behavior analysis. Has been around for a long time and has research to support it. So I've worked in behavior clinics where the focus is on trying to understand why somebody is, for example, hitting themselves in the head, hundreds of times a day, or being aggressive towards other people, and then changing the environments around them, oftentimes focus on increasing their ability to effectively communicate, and then measuring whether those interventions lead to decreases in challenging behaviors. And fortunately, those approaches oftentimes, not always, but oftentimes are effective. I will say there's not a lot of support in the research base for what we call insight-oriented psychotherapy or play therapy for reducing those severe challenging behaviors. Another concern that often co-occurs is safety concerns. I alluded to this earlier, but individuals who have autism are at risk for wandering, drowning, ingesting household items that can be very dangerous, and what's called pica behavior, which is eating substances that most people wouldn't think of as food. For example, rocks or finding cigarette butts, things like that. And you can see some statistics there that these behaviors tend to be fairly common among individuals on the spectrum. So it's just important to be aware of as providers that these are things that the individuals you are working with and supporting may be dealing with in their day-to-day life. There are some nice resources out there. The Autism Society specifically has a lot of nice kind of packaged treatments for caregivers and families on a variety of concerns, including sleep, toileting, and for this talk, wanted to draw your attention to one that they have a series of suggestions, recommendations for water and wandering programs. Other safety recommendations are creating safety plans that include the family as well as the broader community. There are many police forces across the state of Iowa that have received specific training on how to effectively work with autistic individuals and their families. And one of the most important things is to be proactive. In other words, before there's a problem, having a family talk to law enforcement about their children if they are concerned, so that the police officers have some familiarity with who their children are and their tendencies, if they run away, where they may go. There is what's called the Big Red Safety Toolbox. I have a picture of that there. That is a wonderful free resource for individuals who are autistic where there are safety concerns. And that's something that you can just Google and download. There are resources for epilepsy as well. And I've just put examples here of how to draw kind of notice to that if somebody is in a car and they have epilepsy, or having a safety plan related to epilepsy if somebody is having a significant seizure, so that care providers can provide easy, quick, safe support. And this is the adult daughter of one of our colleagues, Chris Steinmetz, who's the executive director of the Autism Society of Iowa. So you can see her daughter here wearing a tag that helps with identification, just in case she happened to wander or if she had a seizure, because she does have a seizure disorder. Other tips to support family members, again, just being very proactive, as I said, seeing if in your area there are specific programs that have been set up, like E911 or the LOSS program, that can provide additional resources, like microchips that can be used or other technologies if somebody elopes. And then seeking out resources like the Autism Society of Iowa, certainly the Child Health Specialty Clinics. They can connect you with resources related to safety. And then I think finally being familiar with the waiver coverage and services that somebody that you're working with qualifies for, is eligible for, and then identifying supports through that, like day hab programming, voc rehab services to support an autistic individual. Crisis management tips. We want to do whatever we can, obviously, to avoid crises. We have a lot more success when we're not in a crisis. Usually we're responding by the time we're in a crisis, right? But if a family member is in crisis, it will depend on the situation. But I typically, if I got a cold call and I didn't have a lot of information and somebody told me there's somebody in crisis, recommending 911, contacting the local hospital, trying to get connected with child or adult psychiatry. If it's less of an acute crisis, then trying to get extra respite or SEL services to help that family kind of navigate some tough times. And then finally, just some other resources. And Kelly, I think you're going to take this part, right?
Yes, I'm seeing lots of great questions in the chat, and I know we're probably not going to have enough time to get through all of them within the hour. We can either stay on and answer questions, or the other thing I was thinking is maybe we can get a copy of the questions from Allison or Erica and then be able to direct people to resources when we send out a copy of the recording today. So go ahead. So a few resources that I wanted to talk about. One, Autism Society of Iowa, which has been mentioned a few times already. This is a state affiliate of the Autism Society across the country. And it's a very active affiliate. They have lots of great programming and conferences and support groups and information on the website and many other things. They're always updating, always adding and thinking about members' needs and what they can be supporting and promoting and doing in the community. So I think it's a wonderful organization. I would encourage everyone to take a look at their website. Here's also their contact information if needed. The second one I have on there is RAP, Regional Autism Assistance Program. This is run through the Division of Child and Health, Community Health, Child Health Specialty Clinics affiliated with the University of Iowa. And these are regional clinics that are across the state. And they have these wonderful folks called family navigators that are parents of kids with special healthcare needs, who are able to connect with families, newly diagnosed families, or families that just have questions or needs, to make sure they're aware of what's available in their community, and also can provide support around specific issues, or just, be there and be able to listen to. So the Regional Autism Assistance Program has a great website as well, and I think I have a link for it later on in these slides. This is a list of applied behavior analysis, ABA providers that take autism support program funds. This is a fortunate thing. There aren't too many people that need these funds anymore, because insurance coverage for ABA programming has gotten quite a bit better in recent years. But if it's still not covered by an employer or something, that is a possible option for people who are looking for ABA. And then here's a little bit more about RAP, one thing that they have as part of their family navigation program is you can, as a provider or service person in the community, can make a referral to their program. It's very easy to do. There's a little referral form, or you could simply reach out to them as well and get them some information to get the family connected with that family navigator. They also have a wonderful guide that's available as a PDF. There's also some hard copies of it floating around. that goes over a lot of the things people would want to consider after their child is diagnosed with autism spectrum disorder. And then here's a couple of websites I wanted you to be aware of. One is the list of state waiver programs, home and community-based services waivers, like the health and disability waiver, intellectual disability waiver, brain injury waiver, those sorts of things. And again, more information about the Regional Autism Assistance Program. So we are right at 1 o'clock, and I do want to thank you so much for coming and for listening to us today. Hope there were some pieces that were helpful for you, and we really appreciate all you're doing out there for families in the community.
Thank you, Kelly and Todd. Thank you, everyone, for joining us today. Have a good day.